It's a great pleasure to welcome Professor Stuart Ralston. Stuart is again well known to many of you, Professor of Rheumatology at the University of Edinburgh, previously in Aberdeen. I've worked a lot with Stuart over the last few years. Stuart was chair of the CHM Commission on Human Medicines, where he did a fantastic job. And Stuart has got enormous amount of work he's done in bone disease, including an ERC advanced grant, which is very difficult to get. So congratulations, Stuart. So Stuart is going to tell us about personalised medicine and bone disease. Thank you, Stuart.
Thanks, Munir, and thanks for the invitation. It's been brilliant. I've so much enjoyed the meeting. So, back to fantasy, personalised medicine and bone disease. Just a couple of conflicts of interest. They're all non-personal interests. A couple of donations of IMPs for clinical trials from Lilly and Novartis, and I'm involved in some studies with the other companies. I thought I'd better look up personalised medicine to remind myself what it was. And it's basically looking at the phenotype of the person and then deciding what is the best treatment, I guess, or maybe to do a preventative intervention. I suppose nowadays we think of personalised medicine as genomics and metabolomics and so on, but actually doctors have been doing personalised medicine for ages with more kind of traditional techniques like imaging. In bone disease, there's a lot of stuff that you could do with it, looking at suitability, predicting the response, modifying the drug dosage perhaps, looking at adverse effects, looking at predisposition, and guiding the need for preventative treatment. And I'll cover some of those in the examples that I'm going to give today. It is really personalised medicine is really in its infancy, I would say, in bone disease, but there is some light on the horizon. Now, I've mentioned before that we have been using personalised medicine in bone disease for a long time. One is in osteoporosis. I'll just try and change the slide. Yeah. One is in osteoporosis. Yeah. So most of you have heard of osteoporosis, I guess, but if you've not, the colour, the left of the panel shows the changes in bone mass with age. So as your skeleton grows, you reach a peak bone mass about the age of 20, then you're kind of static to about the age of 45, and then you lose bone. Both men and women lose bone. And by about the age of 80, about half of all women have osteoporosis. That's the red area. And we define that as a bone density T-score measured by DEXA as less than minus 2.5. So that's the definition of osteoporosis. And perhaps not surprisingly, many, if not all of the trials that have enrolled patients into treatment for osteoporosis have targeted patients on the basis of low BMD. Not all of them won. This was an interesting one called the FIT2 study, and they enrolled people, some of whom had osteopenia, which is kind of slight reduction in bone density, not quite osteoporosis, and a proportion of patients had osteoporosis. And I'm showing the point estimates in the 95% confidence intervals there. And what you can see is the patients with osteoporosis had a 40% reduction in fracture risk, and we see that with many treatments. Yet with osteopenia, there was actually no significant difference. So illustrating the benefit of targeting your treatment on the basis of an imaging criterion. Here was another one. This is with the bisphosphonate risedronate, and this is what's called the HIP study. It was sponsored by Procter & Gamble. They were trying to enroll a very large number of patients. They were trying to enroll 9,000. They started off targeting people with low bone density. They thought, we're never going to get to the target. So what they thought was, we can just enroll older people with risk factors, and that'll be just as good. So it turned out it wasn't just as good. If you looked at the osteoporotic patients, you had a 40% reduction in hip fracture, much as in the previous slide. But if you took patients with risk factors, the effect was blunted. So that's kind of personalised medicine in action, and we've been done that for ages. I'll just use this opportunity to take a swipe at NICE, who are the embodiment of non-personalised medicine in osteoporosis. They came out with this statement in 2017. What they said is, all treatments, well, you can treat if the fracture risk is greater than 4% over 10 years. You don't need to have osteoporosis and DEXA. This one came out slightly later. It was looking at bisphosphonates, and they said you can treat if the 10-year fracture risk is greater than 1% for any bisphosphonates and greater than 10% For IV, again, no DEXA needed. This was picked up by Pulse. Many more eligible for bisphosphonates after NICE lowers the threshold to 1%. I can tell you everyone in this audience should be on alendronate according to this recommendation. Luckily, the MHRA said, wait a minute, boys, not so fast. We don't think this is a good way to go. And in fact, the recommendation were reissued. In fact, the concerns of the MHRA were that there would be widespread use of bisphosphonates, people at low risk, with really no supporting evidence, and it could be causing more harm than good. And in fact, there's a complication of bisphosphonates I'll come into, which will illustrate that. So more onto genetics, which I guess is the theme, genetics and genomics today. Bone disease has a strong genetic component, all bone diseases. So osteoporosis, where it's polygenic in nature. Paget disease, which is a particular interest of mine, where it's oligogenic. So in osteoporosis, there are hundreds of variants. In Paget's, maybe 15 or 20 variants. And then rare bone diseases, which are Mendelian. And if we look at the genetic architecture, you've got the Mendelian diseases, like things like osteoporosis, that's thick bones. Sclerosing dysplasia is also thick bones, osteogenesis imperfecta. Paget's in some cases, rarely osteoporosis, whereas the polygenic, I guess that's exemplified by osteoporosis. Now, is there personalised medicine in rare bone diseases? The answer is yes, and I thought I'd bring out a good example, which is hereditary hypophosphataemic rickets. So it's a rare disease, 1 in 20,000 estimated. It's usually caused by phosphate wasting in the kidney, and you get all sorts of problems like growth retardation and limb deformity. You get stress fractures, as shown here, and later in life you get what's called this enthesopathy. It's a kind of osteoarthritis type phenotype with osteophytes. It is a bit of a problem. Now, there are many genes which cause hypophosphatemic lickets. The most common one is XLH, that's the FEX gene. This one is caused by mutations in a gene called FGF23, and this one by DMP1. The thing that puts all these things in common, all these three genes in common, is that the levels of this hormone, FGF23, in the blood are raised. These gene mutations also cause hypophosphatemic rickets, but FGF23 isn't raised. So this obviously gives you a target, a therapeutic target for patients where FGF23 is raised. And what happens is, under normal circumstances, FGF23 is released into the circulation, it's broken down by proteolysis and then activated. With these two genes, you get dysregulation of FGF23. I'm not sure why, but there's too much of it made. In autosomal dominant, there's a mutation in the protein that stops it being cleaved. But in all three cases, you get a raised level of FGF23, you get phosphate excretion going up, big leak from the kidney, and vitamin D or active vitamin D metabolites reduced, and that causes rickets. And this was a great example of how a personalised treatment was developed for this condition. We used to treat it with phosphate supplements and active vitamin D metabolites. But this medicine, burosimab, was licensed, I think, a couple of years ago now, as I recall, in children with FGF23, and it just has transformed the life of these patients. So this is a paper in The Lancet, one of the best papers, I think. Conventional therapy, so that's active D metabolites and phosphate in the red, burosimab in the blue, and the rickets was healed, the deformity was healed. That's just a huge thing. You could hardly ever see that before. And ALP reflecting osteomalacia or rickets falling in the burosimab group. This treatment also works in adults. We've taken part in this trial with a few patients with this. So this was the placebo-controlled arm. So this is burosimab, and this is looking at, I think it's healed pseudofractures. 43% versus 7% placebo. And then everyone get transferred onto the active treatment. And it has transformed these patients' lives. So that's a great example of personalised medicine. I'll move quickly on to another opportunity, but one where we don't have much evidence. It's osteogenesis imperfecta. Many genes cause, mutations cause this. Most common are mutations affecting type 1 collagen. This is one of the first diseases where the causal gene was found, actually. I mean, it goes back to the 1960s. But still, we don't have a very good treatment. What happens is the collagen is either produced in not enough amounts or it's abnormal in structure. And the fracture rate is huge in both females and males. It peaks in the ages of between about 5 and 10 and then gradually goes down. But throughout life, people with OI have about 100 times greater risk of fracture than individuals who don't have OI. So treatments for osteogenesis, although we've known about the disease for a long time, advances in treatments really have not kept pace with knowledge of the genetics. There are no licensed treatments for osteogenesis imperfecta. I think that's partly because the clinical trials haven't been done, which is a bit of a bit of an indictment. What we instead use is off-label treatments that are used in osteoporosis, things like bisphosphonates, denosumab. Not sure if these work, they're widely used. There's no information in genotype-phenotype response, but we are doing a trial at the moment called the TOPAZ trial. It's the acronym there, treatment of osteogenesis imperfecta with parathyroid hormone and zoledronic acid. So parathyroid hormone, or teriparatide, the 134 fragment, increases bone formation, and then it stabilizes the increase in bone formation with zoledronic acid. And the two treatment arms are teriparatide ZA versus standard care. We're hoping to enroll 380 patients. This, of course, don't ever do a trial in the middle of a pandemic. We got to about 60% enrollment. Then the pandemic hit. The trial was closed down for nearly 18 months, although we've just started to enroll again. And my application to the EMA for more money is in process. So we don't know if either of these, if this treatment will work, but we've got genetic profiling in everyone, so we know the mutation. It'd be very interesting to look at the influence of gene mutation on the response to these strategies. So that's work in progress. Watch this space. It might finish if I live to see the day, okay? My retirement has already been delayed. Now, one of the diseases that I am very interested in called Paget's disease of bone. This is the subject of my ERC Advanced Investigator Award that Sir Munir mentioned. So it's a fascinating bone disease. It's caused by abnormalities in what's called the bone remodeling process. Now, throughout life, our bone is remodeled. And in Paget's disease, it goes crazy. The rate of remodeling just racks up to maybe 5 or 10 times what it should be. And it affects focally different bones. So this patient has Paget's at the base of the skull, the scapula, both sides of the pelvis, and both femurs and the lumbar spine. And what's causing this is these are osteoclasts, or bone resorbing cells, going crazy, eating a big hole in this bony trabecula, and there's osteoblasts moving in alongside to lay down new bone. Unfortunately, the process is rapid, it's chaotic, and it weakens the bone. And that can cause various complications like pain, the bones get bigger, they bend, there's deafness, fractures, deformity, rarely osteosarcoma. So it's a morbid disease, a very strong genetic component. These are the main genes that we know predispose to the disease, either by GWAS linkage or genome sequencing. And for all of these genes, there's very robust evidence of association with Paget's disease. They're large effect genes, okay? So for the GWAS genes, the effect size is something like 1.6 to 1.7. So that's way bigger than in osteoporosis, for example. So all of the genes seem to affect the osteoclast. Somewhere along the pathway, the CSF1 gene, early differentiation, these genes again affect osteoclast differentiation. This gene affects fusion of osteoclast precursors, and these genes are involved in NFKB signaling and autophagy in osteoclasts. And I'd just like to focus on sequestosome 1. That's the most important one. If you take a bunch of clinic patients with Paget's disease, about 15% will have a mutation of this gene. If the clinic patient has a family history, there's a 40% chance they'll have a mutation, but these mutations are rare in the general population. Now, if you've got a sequestosome 1 mutation, that's the red bars, you're more likely to require treatment in the past, more likely, albeit not significantly, to have bone deformity. Again, not significantly, but more likely to have a fracture, more likely to have had orthopedic surgery. So it gives a severe phenotype. So if you've got a sequestosome 1 mutation, you've got a severe phenotype. And we're doing this trial, which is an example of personalised medicine in action. It's called the ZIPP trial, the Zoledronate in the Prevention of Paget's Disease. And what we've done is we enrolled people with a family history of Paget's disease. We genotyped them, and if they tested positive for sequestosome, we invited them to enter the trial. And they either get randomized, double-blind, to zoledronic acid or to placebo. The idea was to follow them up annually between 5 and 8 years. Read 7 and 10 years now. And then we look to see if there's any Paget's disease at the end. And we also look at adverse effects and symptoms. So it's a multi-center, multinational randomized trial. We recruited 220 patients, 222 patients into the study starting in 2010. The end of trial visits were meant to be completed by 2019, but they've been delayed by about 2 years. We're hoping to get all the end of trial visits done by the end of 2021 and have the results available by 2022. Just so some data from the baseline characteristics. We published this. So this looks at the age at baseline. If you don't have an early lesion, in other words, that's early Paget's disease, you're a bit younger than if you do. Lesions, i.e. Paget's disease, more common in men than women, and that fits with what we know. Paget's is slightly more common in men than women. Interestingly, we found about 9% of people on entry to the study, they were average age 50, already had Paget's disease, but they didn't know it. They had no symptoms. So we were picking them up at an early stage. We have to watch this space. I've been going through with my radiologist colleagues the end of study bone scans. Here's one. That's the baseline bone scan. I appreciate not many of you are metabolic bone physicians. That's Paget's disease of the pelvis. That's the end of study scan. The Paget's disease of the pelvis has completely disappeared. I don't know whether, because obviously we're doing this blind. I'm hoping he got zoledronic acid, but I don't know. And we're just, if he got placebo, this could be a new direction. But anyway, so the idea is that Paget's disease, it's not as though you can predict it by, I don't know, smoking or alcohol. There's not an environment, well, there's probably environmental influence. There's nothing you can measure. So if you have a family history, you could envisage a situation for testing for genetic risk alleles, not only sequestosome 1, but the other one, round about the age of 50, and then entering those patients either to an enhanced surveillance program or possibly, depending on what the ZIPP study shows, prophylactic therapy. And here's a baseline scan in one participant. This caused a bit of consternation when we saw this, and it's Paget's disease of the cervical spine. This patient was completely asymptomatic. I mean, he was playing five-a-side football, and we had to call up the study centre and say, can you get a neurosurgeon to see this patient immediately? But it turned out he had no symptoms. This was a stable lesion, and they haven't done anything. But there you go. So it's quite an interesting approach. Now, what about osteoporosis? That's the most common bone disease. What are the prospects for pharmacogenetics or personalised medicine in osteoporosis? Well, as I've alluded to, it's a polygenic trait. It's mostly common variants. This is a genome-wide meta-analysis, and at the time this was published, 2012, a little while ago, there were 57 loci for BMD and 14 fracture. And the genes, or the hits were near genes involved in regulation of bone formation and bone resorption, few fracture genes. Small effect size variance, and about 6% of the variance in BMD was explained. We've heard about UK Biobank, and of course this is a huge increase in sample size. There was a GWAS for, this is heel ultrasound. They call it eBMD, but it's a bit naughty. It's actually heel ultrasound. But this is 500,000 people. And suddenly, instead of 56 variants, you've got like 518 variants. So, and there is overlap between some of these and bone density variants. And I know that I think that there's a GWAS going on the bone density component of UK Biobank, and I'm sure we'll have many, many more variants coming up. With the BMD, about 20% of the variance is explained, which is quite interesting. There have been attempts to use a polygenic risk score to see if you can improve fracture risk. There's many papers in this. I'm just going to show one. So this is for major osteoporotic fracture. These are kind of things we know matter: high levels of alcohol intake, falling, rheumatoid, and so on. That's where BMD is. So if you have a low BMD, that's a good predictor. And this is called GSOS. It's genetically predicted ultrasound. And so it is predictive, but maybe not massively so, not as good as bone density. What the investigators did in this study is they looked at FRAX, which is a clinical risk factor score, FRAX plus GSOS, which is kind of slightly different, but not that much different in FRAX plus BMD. And I think the bottom line is we're not there yet with this change in clinic. I cannot see this change in clinical practice at the moment, but there may be options to do so. So as I've mentioned, there's some value with using genetics to predict occurrence of fractures, not much of an advance over clinical risk factor analysis. My feeling is, though, there could be a role for genetics. There are some people that we do not pick up by clinical risk factors, like early onset osteoporosis. You see these people, age 40, and they get often quite severe osteoporosis. Why? Presumably genetic. This rare condition called pregnancy-associated osteoporosis, I'm pretty certain is genetic. And also severe spinal osteoporosis, again, another condition where we can't pick those up very well. And when we have the studies coming in to look at this, I think there may be a way forward for polygenic risk scores. Now, winding up, looking at predicting adverse events and treatment response. Now, adverse events first. I'd like to highlight two adverse events of bisphosphonates. They're both rare adverse events. One is what's called atypical femoral fractures. So this is when the patient has maybe been on alendronate for 10 years. They suddenly get pain in their thigh, and they get often a spontaneous or low tremor fracture. And this is thought to be due to oversuppression of bone turnover. This is one of the reasons why the MHRA was so exercised with NICE advising that people with a very low fracture risk get treatment with alendronate, because you would have seen a lot of these coming up. So it's a rare condition, 78 per 100,000 patient years. The other one that deserves mention is ONJ. This is mainly with high doses of intravenous bisphosphonate in oncology, and that's about 1 in 100,000 patient years. It depends which data you look at. It's a nasty complication, though. Typically, a patient has a tooth extraction, the socket doesn't heal, and you get necrotic bone at the bottom. So both of these are rare. And there have been attempts to try and find out, well, could this be genetically determined? With AFF, there is evidence of that. People of Asian descent are more susceptible, so that gives a hint towards a genetic component. There have been studies, GWAS studies, of bisphosphonate-associated AFF. No significant hits yet. And I think, Sir Mooney, you took part in a study in ONJ, actually. But this was a review last year in the journal Bone. And there haven't been really any convincing hits for either of those phenotypes. So there's probably more work to be done. These are rare conditions. The sample sizes have been small. That's been a limiting factor. And, it could be we might get there in the end, but certainly we aren't there at the moment. What about treatment response? Well, there's very little data. I mean, bisphosphonates are the most widely used drugs. There's a handful of underpowered standard 8 gene studies that really don't deserve mention. Denosumab, that's one we use a bit, no data. Raloxifene, HRT, romosozumab, no data. And I think the problem is when the studies of these drugs were going through, maybe 10, 15 years ago, the companies did not collect DNA. So we have no data from these studies, which is a crying shame. With teriparatide, we have some recent evidence that the response is influenced to genetics. So teriparatide, I mentioned that, it's an anabolic drug. And this is data which we've generated in Edinburgh with collaborators in where is it again? St James Cook Hospital in Northern England and Aarhus, University of Aarhus. And we looked really at the response of bone density to teriparatide and did a GWAS. So this is the GWAS, and a couple of suggestive hits here, but this was a highly significant hit at the CR4 locus. It was p times 10 to the minus 9 in replication as well. That's the GWAS, but the replication held up. And what this shows the allele at this SNP. And so AA is the good genotype, AG is the heterozygote, and GG is the bad genotype. And teriparatide, I should say, mainly works on spine bone density. That's where its biggest effect is. But what you can see is there's a very robust anabolic effect if you're AA. It's about 16%. You still get an anabolic effect with GG, but it's about half as good, okay? And this could be actionable, actually, because when we did this study, this was the only anabolic drug available. Now we've got romosozumab, which is another one, and it could be if you're GG, Maybe you shouldn't have teriparatide. Maybe you should have romosozumab. So still, we're submitting this paper for publication, but it does show you that teriparatide treatment is influenced quite significantly by variants at this locus. And the top SNP was an EQTL for expression of CXCR4. So it's probably affecting gene regulation. So there we go. Bone disease, fact or fantasy. Bit of fact, bit of fantasy. We have been using personalised approaches for a long time in bone disease. I think, though, that genetics will offer the prospect of advancing things further. I think it is a crying shame that genetic studies have been absent from these big trials. And I was speaking to the people from UCB who made romosozumab. That's recent. And I was saying, you didn't by any chance collect data on genetics? And they said, no. And I thought, that's horrendous. How dare you? Anyway. But there may be a possibility for people like myself involved in the field to do investigator-led studies, because it's kind of case-only study giving a treatment. And I think that could be a way forward. Okay, Sir Munir, thank you so much for the invitation. Thanks for your attention. Thank you.